Okay, dear Chairman, dear colleagues, I'm happy that I can comment on these very interesting two cases. And I would like to address four questions. First of all, what therapeutic options do we have in locally advanced pancreatic cancer? Do we have biomarkers for gemcitabine efficacy? Because this has been an extraordinarily successful case of gemcitabine treatment. And what is the role of chemoradiation in locally advanced pancreatic disease? And are there markers for therapeutic efficacy? In the first case, we had this very prolonged survival on gemcitabine. In the second case, we had chemoradiation with no residual disease, but still peritoneal carcinosis. And when you were given the choice what to actually choose as treatment, most of you choose gemcitabine. Quite a few already opted for FOLFIRINOX. And when you consider the goals, what we actually want to achieve is, we want to prolong survival on the one hand, and maybe in some instances we are able to achieve resectability. This is possible in up to 30% of patients, according to which paper you actually read, with locally advanced pancreatic cancer. The ESMO guidelines clearly state that patients may benefit from neoadjuvant chemotherapy or chemoradiation to achieve downsizing of the tumor and may convert the tumor to being resectable. So this is a meta-analysis that also shows this fact, and we do have to consider that in locally advanced PDAC we have two different scenarios. One is the borderline tumors that are not quite resectable but may become resectable later on, and neoadjuvant treatment is definitely rewarding. On the other hand, we have in this locally advanced PDAC also those cases that will never ever become resectable and will be subjected to palliative treatment. But only 1/3 of those borderline resectable tumors do at the end become resectable. And the ESMO guidelines also state, and this is, I think, very important, that this neoadjuvant treatment also gives us information on the tumor biology. So those who actually progress under this neoadjuvant treatment are definitely no candidates for any kind of resection. And bearing in mind, when we want to achieve resectability, we want to get response. So we need at least a major response. The partial or minor response obviously does not really correlate well with subsequent resectability and survival of the patients. So we want to have a chemotherapy that actually is efficient. Here I just put you together all the data available on different chemotherapy regimens, and you will see that in the response rate in gemcitabine alone varies quite a bit, from 7% in one studies up to 13.3% in some other studies. The median progression-free survival is between 2.3 and 3.9 months, and the median overall survival between 5.6 and in locally advanced pancreatic cancer up to 10 months. This is the one we are looking at the moment. And you see in red those who actually have become very successful. This is gemcitabine plus CAPE, 19% response rate. Gem plus oxaliplatin, 26% response rate. Nab-paclitaxel plus gemcitabine, 23% response rate. And FOLFIRINOX, 31.6%. But only the latter two also succeeded in achieving an improvement in overall survival, whereas the other one, some of them actually achieved an improvement in progression-free survival, but not all of them did that. So this is the matter of fact what we have at the moment. The ESMO guidelines still state, and this is what the majority of you also thought, is that in patients with unresectable tumors, gemcitabine treatment in conventional dosing is recommended. And you see that this can be a very successful strategy. Other strategies may be intensifying the treatment to really get a more appropriate downsizing. This could be done with FOLFIRINOX, as you've just been hearing in the previous talks as well, that there are interesting options, but FOLFIRINOX, I would like to remind you, has been only tried in patients below the age of 75, ECOG 0 to 1, and with a bilirubin level less than or equal to 1.5 of the upper limit of normal. But there are, and I don't want to show you the same data as you've just seen before, this is another trial, which has been shown in ASCO GI in 2011, very small trial, but they showed that they can achieve zero resectability in a substantial number of patients with locally advanced pancreatic cancer, and they of course fare much better when they can be resected upon. So, and interestingly also, as you heard in the previous talk, in this trial, toxicity in the neoadjuvant setting with FOLFIRINOX was lower as compared to the palliative setting. So there might be also a hint that FOLFIRINOX might be a more interesting treatment in the neoadjuvant treatment with respect to toxicity. What about nab-paclitaxel? The interesting bit about this regimen is that in combination with gemcitabine, this has been tried in patients even above the age of 75, and even in patients with a Karnofsky performance status of 70. So it's actually a broader area of patients that has been examined, but again, only in the metastatic setting. But patients had to have a normal bilirubin level, not even a slightly elevated one. But again, you've seen these substantial improvements in progression-free survival as well as in overall survival using the combination. And there has been, on this year's ASCO, a presentation by Mukherjee and colleagues, and they showed in potentially resectable pancreatic cancer what is the regression grade when you actually use nab-paclitaxel gemcitabine. What they could show is, which I find very interesting, that in up to 30% of the patients, you get a grade 3 to 4 regression of the tumor upon treatment with these two drugs. And you see the grade 3 is more than 90% tumor regression, and the grade 4 was absent of viable tumor cells, which was detectable in one patient. This is again a small trial, but around about 30% major responses can be achieved, and this is almost the figure you achieve with the FOLFIRINOX protocol, as you've seen previously from the other talk. So there might be also a marker for the efficacy of this combination. This is SPARC. SPARC is a matricellular protein which is present in the tumor as well as in the matrix, and high expression in the stroma of the pancreatic tumor correlates with a worse prognosis. And interestingly, and these are preliminary data still, but I think quite exciting data, a high level of SPARC in the tumor actually confers a better prognosis when you treat patients with gemcitabine plus nab-paclitaxel. The data from the MPACT trial are still not yet available. So gemcitabine is still standard. FOLFIRINOX and the combination of gemcitabine plus nab-paclitaxel are interesting options. They may have a higher toxicity, but also a higher chance of tumor regression. There may be also a higher chance of secondary resectability. And we have to define still who is eligible for this treatment. There are prospective trials warranted, but they're on their way, and I think we will get soon the appropriate data. So in the first case presented, the patient benefited from gemcitabine very well, and gemcitabine has low toxicity. So do we have any markers to actually check for efficacy of gemcitabine? And one of these markers already was mentioned by Pascal Hamel is the HENT1. Gemcitabine has to get into the cell, and one of these nucleoside transporters that is really important for gemcitabine is the HENT1. And there has been previous data from the RTOG trial showing that in contrast to 5-FU, expression levels of HENT1 are actually relevant for the efficacy of gemcitabine, as you see. On this year's ASCO, John Neoptolemus presented retrospective analyses of the SPEG1 and SPEG3 trial. And again, he could show using a novel antibody they developed against HENT1 that indeed high expression of HENT1 corresponds to a very good prognosis under gemcitabine treatment as compared to a low expression of HENT1. This is not the case for 5-FU. This works independently of the HENT1 levels. In the metastatic setting, it was a little bit different. There was data from Elizabeth Poplin. She compared in her trial a lipid-modified gemcitabine, which doesn't require the transporter to get into the cell, with gemcitabine. They stratified according to HENT1 expression levels. And interestingly, there was no difference between this CO101, which is the lipid-modified gemcitabine, and gemcitabine itself, either in the whole population or in the HENT1 high or low tumors. So we are a little bit at loss what that's supposed to mean. They used a different antibody. They used the same as it has been used in the Farrell trial. But we do have a significant correlation in the adjuvant setting. In the metastatic setting, we don't know yet, but we also don't know whether this is due to a low efficacy of the CO101 or whether this is due to an antibody problem, and we should probably compare both the Ventana and the antibody used by John Neoptolemus in a similar setting, but these data are going to come. So in the second case, chemoradiation was used. And there is an issue whether we should choose a local treatment for a systemic disease. And if we do so, how should we apply it? Why am I saying this is a systemic disease? The similar group, as you already heard from Margaret Tempero, has made a computational analysis to really see how does pancreatic cancer grow and what is the likelihood of metastases being there already at a very early stage. And they came up with quite interesting findings. First of all, they could show that pancreatic cancer is growing exponentially and not linearly. Secondly, they found that cells with a metastatic potential are generated during the tumor expansion and around about 1 cell per 1 million tumor cells. And also very small tumors, as you see here on the right side of the panel, tumors with a diameter of 2 centimeters have a chance of 40% of having metastatic cells. So there is a primary metastatic character to pancreatic cancer. The majority may have micrometastases even at a stage where we actually consider them easily resectable. So how can we define who has localized disease and is eligible for localized treatment and who actually has not? The question is, what is the value of chemoradiation or chemotherapy? And this is a meta-analysis by Huguet done in 2009 already, and what they found is chemoradiotherapy is better than radiotherapy alone, but when you compare that to chemotherapy, you have large confidence intervals, and there is no significant difference between chemoradiation and chemotherapy so far. This is one of the few trials by Löwer and colleagues showing that there is an advantage in survival when you use chemoradiation with gemcitabine as compared to gemcitabine alone. The trial had to be ended prematurely due to poor recruitment, and the overall survival benefit was about 1.9 months. However, there was a substantial increase in grade 4 toxicity from 5.7 to over 40% in those who got the radiation treatment. The authors report that there was no difference in quality of life, but interestingly, those who actually got the radiochemotherapy had a higher rate of distant metastases. So we actually have a local means, but we don't really address the systemic disease. Retrospective analysis, also from Huguet, suggested that those patients who actually are stable on initial chemotherapy may benefit from a later introduced chemoradiation, because then you get to know tumor biology better, and you may actually pick out those who actually remain stable for a longer period of time and are not primarily metastatic. And this has been examined prospectively in the already mentioned LAP-07 trial, where chemoradiation with capecitabine was compared to the chemotherapy alone. They used a 4 months chemotherapy introduction to actually learn the tumor biology, and only those who did not progress were randomized. Unfortunately, this trial did not show any difference at all between the chemotherapy arm and the chemoradiation arm, and so we are not the wiser regarding the value of the chemoradiation. And in this case, the chemoradiation was extremely well controlled. There was a European panel defining the treatment. There did dummy runs on the quality of the treatment applied. So this is actually a high-quality trial. There might be a long induction time. Maybe this time is too long. We don't know. And there might also be a question whether capecitabine was the right combination partner for the radiotherapy. However, when you look at data recently presented at ASCO GI this year, this is the British SCALLOP trial, very similar protocol with a GAMCAP induction treatment followed by chemoradiation. This trial clearly showed that there is at least no disadvantage combining capecitabine with radiation as compared to gemcitabine with radiation. So at least both protocols are equal. Capecitabine did actually better than gemcitabine with respect to overall survival, but it was a small trial that was primarily intended to set up quality criteria for these kind of trials in the United Kingdom. Interestingly, toxicity with capecitabine in combination with radiation was less. So what did the ESMO guidelines say? The trials comparing chemoradiation with chemotherapy alone reported contradictory results. I've shown you some of these. The optimal neoadjuvant strategy is still under investigation, and there is so far no standard protocol for neoadjuvant chemoradiation in Europe. Getting these all together, you've seen two very interesting and very convincing cases. The neoadjuvant treatment strategy will allow downsizing and maybe secondary resection up to 30% of patients with borderline resectable locally advanced PDAC. The best chemotherapeutic regimen for this situation has still to be established. Novel combinations such as FOLFIRINOX or gemcitabine plus nab-paclitaxel are promising, but only in early phases. We need the more advanced and more mature trials. Gemcitabine does remain an option in patients with locally advanced pancreatic cancer, and as you've seen here, it does work very well. And the role of radiochemotherapy in these patients is still unclear and subject to further clinical trials. Some patients benefit from this treatment, but currently, unfortunately, we cannot really predict who that is going to be.